wide-eyed everybody else. Surprise to me too. I never knew he was one of us. So anyhow, thank you.
He is, and thank you, Gwen. He is here, and
oh, okay, good.
I'll take this opportunity to introduce him.
Good, and send the archive address, folks. Thank you.
Okay.
I'll do that. I'll do that, Gwen.
I've already given the T-shirt.
Pardon me?
I've already given that T-shirt, so you can keep yours.
Oh, thank you. Because it finally fits. It used to be too big.
Okay.
And now it shrank.
All right, let me introduce Dr. Frieden. As you all know by now, he's a former director of the CDC and under the Obama administration, and was a former commissioner in the New York City Health Department. He attended Oberlin, and as best I can tell, he graduated in 1982, which I think was the year that he worked for the Student Health Coalition. He went to medical school at Columbia P&S and got an MPH there, did a medical residency there as well, and then did specialty training in infectious disease at Yale. He currently is the president and CEO of Resolve to Save Lives, which is a global nonprofit that's funded by a pretty heady group of philanthropies, Bloomberg, Zuckerberg, and Bill and Melinda Gates Foundation, and is part of the Global Vital Strategies nonprofit. And their work is to work with countries to prevent deaths and make the world safer from epidemics, which is about as appropriate as we could get right now. We are pleased to have him join us, and I've sent you a brief description of what he did in the Student Health Coalition, and maybe Sonia can, Sonoe, can repost that. For Dr. Frieden's own awareness, I'll tell him that Dr. Rasmussen and Jean Carney are both online as well. So we welcome you to our discussion.
Great. Well, it's so nice to see you all. I really can't, I can't say enough. Sonia, I had no idea you were one of us. And Jean, it's so nice to be in contact again. Just fantastic. I've got an hour with you. Is that correct? Basically from 11 to 12 my time. And you wanted me to talk some about COVID. Is that right?
I think that would be excellent.
Okay. I would also love to get all of your thoughts about primary care, because I think we're going to have to revision it for the U.S. But I just wanted to say a few things. The experience I had with the Appalachian Student Health Coalition Center for Health Services really was formative for me. My mother was just, I mentioned, now with Zoom, we have a family reunion every Wednesday night with my family, my extended family. And so my mother, who's 90 and very lonely at home, she usually goes out and sings in 2 choirs, goes to 3 book clubs, goes to a movie every night or a show. She's really suffering from this. So she reminded me, I forgot, that what I did was I graduated from Oberlin, and then I got onto my bicycle and I rode through Ohio, through Kentucky, and down into Nashville to start the Center for Health Services program. And I was assigned to the Douglas Community Health Center out in extended Mississippi Delta area outside of Memphis. And it was not doing well, didn't have many encounters. And I had no idea how to increase encounters in a community health center. I'd been a philosophy major in college. And so I went to the business school, and I had the idea of doing a random, I've never written this up. I will write this up at some point. I did a simple random sample of 500 households in the 10,000 person catchment area, going census block by census block. And then I did about a 10-page questionnaire for each household. I think I only had 2 refusals. One of them, it was largely an African-American community. One of them, I think the young girl was alone in the house. And so when I drove up with this car that Vanderbilt had loaned me, this old, huge Chrysler, this white guy getting out of the car, this 11-year-old girl had a shotgun over her knee, kind of pointed in my direction. And I said, doing a survey, you're allowed to refuse. You're refusing? So other than her and one other person, I had a 100% response rate. And what it showed was very, very delicate. What it showed was that the African-American doctor, first off, it showed, really interesting, showed that half of people in the catchment area didn't know the clinic existed, didn't know it existed. 80% of the people in the area didn't know that it used a sliding fee scale. And almost nobody knew that they had a van that would pick you up and take you there. And if you looked at who knew, it was the people who didn't need to know. So it was that old inverse care law all over again. The people who didn't need to know these things knew them, and the people who needed to didn't know them. And this led to my first real lesson in organizational life, that communication is never as good as you think it is. If you think it's good, it's fair. If you think it's fair, it's bad. If you think it's bad, it's terrible. But when I was staying with families, the survey was unequivocal in that beyond that nobody knew about it, people who did know about it didn't like the doctor. Doctor was black, married to a white woman, and the perception was he didn't treat black people well. Dentist was white, and I heard over and over again, the doctor don't treat us right. That white dentist treats us a lot better than that black doctor. He talks down to us. He's rude to us. And it was a really delicate position. Here I am, I don't know, 18 years old or whatever, right out of college, or 20-year-old, right out of college. And I was staying with an African-American family. When I was writing up, I had to present to the board. Gene may remember that. I had to present to the board the next day. I'm really nervous. I've never done a presentation like this. And I say to the woman of the house, I have a problem. I don't know what to do. And I explained everything to her. And she said, honey, is that what the people told you? Then that's what you got to say. You got to tell it like it is. So that was really a formative experience for me. It was very uncomfortable. I'd love to learn more about primary care in the discussion section of this. Let me just talk to you briefly about COVID. This is obviously one of the biggest public health emergencies of our time. Actually, it's the most disruptive public health event in a century since the great pandemic of 1918. And the more we learn, the more we realize it's bad, and it's just the beginning. There's going to be a risk of explosive spread until there's a vaccine. Vaccine could be months or years, and a vaccine isn't like flipping a switch. Getting a vaccine is just the beginning of getting it into people's arms and figuring out if there are bad reactions, does it work well, are people going to take it, how are people going to get it? It's a public health emergency, and my group works all around the world, and what we find is the places that are guided by public health do better. They have fewer deaths, less disease, and less economic devastation. I've called it World War C. It's humans against the coronavirus. But we're learning a lot, and the shutdowns that happened around the world saved millions of lives, millions. It's hard to imagine just how fast this virus moves. And it's, let's be frank, it's a bigger risk in urban areas. It's a bigger risk in congregate, crowded places like meatpacking factories and nursing homes and jails and prisons and homeless shelters and multifamily households. But in New York City, this was moving so fast, it was doubling every 2 or 3 days. And what that means is we've lost 25,000 New Yorkers from this. What that means is if we had waited 3 more days, it would have been 50,000. Another week, it would have been 100,000. But if we had done it, if we'd locked down a week or 2 earlier, we would have saved at least 10,000 lives. So you really have to take this one seriously. We did flatten the curve, everyone understands that concept, but that's just to get ready for it. I feel like we have attention deficit disorder in this country. We can only think of one thing at a time. Oh, let's shut travel from China, then we'll be safe. I mean, what kind of magical thinking is that? It's going to miraculously go away? Or we'll all stay home for a month and then it'll go away. No, it's still there. We're tired. It's not. It's a virus. Or just test everyone. That'll work. No, testing does nothing unless you isolate, contact tracing, quarantine. So I think the key also is understanding that get past false dichotomies. This isn't about closed versus open. We were never fully closed. We won't be fully open unless we have a widely available vaccine that's widely used. It's a question of a dimmer dial. How do we gradually improve our economic presence without risking people's lives? And it's not about health versus economics. Yogi Berra said, if people don't want to come to the ballpark, how are you going to stop them? And if you open up and people are afraid of dying if they go shopping, you're not going to restore the economy. Some people will go, but a lot won't. I've been talking about the 3 W's: wear a mask, wash your hands, and watch your distance. And I think in public health, we have to keep it simple, keep the messaging simple. You see so much. I had an article this morning in the Washington Post. I've been writing and writing. I don't really like writing, but there's not a lot of people doing it accurately. And I'm seeing a lot of really foolish stuff written. And, you know, there are, I was told, 350 New York Times reporter working on this full time. And so that, you know, they'll stick a microphone in front of anybody and who's got, you know, public health in his name or her name. And they'll say anything. And the more outrageous things they say, the more reporters go listen to them. So you see a lot of really, what I call in print, clueless epidemiology. And so the Washington Post, we can send a link around to that, but talks about this. One of the things is, oh, herd immunity. Herd immunity? Herd immunity means 60, 70% of Americans get this and 2 million Americans are dead. More than have died in every war in American history. You kidding me? Herd immunity means we'll crash our economy for years. So not a lot of understanding. And testing, really important, but useless unless it's part of a comprehensive strategy, what we call the box it in strategy, which is test, isolate, contact trace, and quarantine. Contact tracing, really important, but it's part of a program. It's, are you treating patients and contacts of the VIPs of the program? Are you able to find them quickly, isolate them quickly? We look all around the world for best practice. Singapore is doing a great job. New Zealand has crushed the curve. They basically restarted their economy. You can go out now. It's as if it's not there. What did they do? In New Zealand, their goal was at least 80% of people were isolated within 3 days of feeling sick. So from symptom onset to test was 2 days, from test to isolation was a day. Singapore, they were just sharing some of their data on a conference this morning. 2,000 cases, they identified 2,300 cases, they identified 2,600 contacts, 11 contacts per case, and they quarantined them. There were 583 cases that arose from those contacts and no secondary transmission that they could find from those 583 cases, so that the cases dead-ended with them. So this approach is really important, but it means putting people first. And it's been painful to see that marginalization of public health and healthcare. And it's true at the US level, it's true at New York State, it's true at New York City, it's true in many places. And yet the places around the world, like New Zealand, Iceland, Rwanda, Uganda, Vietnam, Germany, that have, Korea, Singapore, that have been guided by public health and supported public health, had fewer deaths and their economies are bouncing back faster. When people heard, oh, contact tracing is important, we immediately heard two things from the, commentariat. One was, oh, anyone can do that. Like, no, it's really hard. It requires specialized skills. You have to be detective, you have to be social worker, you have to be resourceful, you have to understand medical issues and confidentiality, you have to have people skills and resources, you have to develop trust, you have to be really organized and supportive, you have to be well supervised. So no, anyone can't do it, it's hard. And then we heard, oh, an app will take care of that. We'll just get Google and Apple and you'll wave your phone around and figure out who you were exposed to. Nonsense. It's a total distraction, not gonna work, and it scares the bejeebers out of people. So contact tracing is really important, and CDC is now doing work to scale that up. State and local entities have to scale that up, and community health workers are going to be very important. How do we support people? How to reach them? How do we make sure we're addressing their needs? Isolation and quarantine. We're going to need to find places for people who are living in homeless shelters or multi-generational houses who have the infection and maybe who have been exposed. Otherwise, you get more spread. What we're seeing now in the US is infection rates coming down in all population groups except kids, where they're stable or increasing. And what's probably happening, not certain, but probably happening, is that adults are taking it home to their kids and the kids are getting infected. Public health, so we're going to need to support people in isolation, care packages, emotional support, access to medical care, telemedicine, and that's in all of our best interest. We made a single slide of the best practices in contact tracing from around the world. I really like this. It was care packages, there were services, and there was support. Care packages, everything from doing your laundry. You know, you have someone to stay home for 2 weeks. If they don't have a washer dryer in their home, what are they going to do, right? How are they going to get food? How are they going to get their medicine if they need it? How are they going to get clean things if they live with other people? So care packages for people in quarantine. And then for people who, services like telemedicine so that they can get care if they need it, and social services. And then support. The best places in the world that we've seen give people things like unlimited Netflix. Please stay home for the next 2 weeks. And also, if they were working, paid them to stay home, just like jury duty. $500 for 2 weeks, stay home. Otherwise, they're going to come out and work, and all of us will be less safe. Public health aims to improve health for as many people as much as possible. Primary care deals with the patient in front of you. I like to say that an epidemiologist is someone who loses sleep over denominators. And so we really think about scale. And at my group, Resolve, we think our three main principles are simplicity, speed, and scale. When it comes to primary care, we asked a really simple question many years ago when I was New York City Health Commissioner. It's one of those kind of questions a child would ask. We said, well, we were putting in electronic health records, which we naively thought would make a big difference. We said, well, now that we've got these records in, what should we do that will save the most lives? It's a simple question. What will you do in healthcare that will save the most lives? And interestingly, we could not find the answer. More than 10 million articles in Medline couldn't find an answer. There was a group called Archimedes that kind of did it, but not really. So we had to do the analysis ourselves. And it was actually slam dunk, straightforward, no question. And Bill knows this, it's hypertension control. Hypertension control is the biggest potential win of healthcare. So with many others, we tried something called Million Hearts in the US, and I'll be frank, we made very little progress, if any. Maybe we delayed the decline a little bit, but we really didn't make much progress. And we really tried. I mean, Bill Core can speak for this. We met regularly. We changed metrics. We got HRSA and the whole alphabet soup of HHS to promote it. We did a lot of media, and it didn't really work. I think because fundamentally, the financial incentives are wrong in our healthcare system. And as we say in New York, excuse my language, but money talks, bullshit walks. And, you know, unless we're putting our money where it matters, we're not going to see a different healthcare system. Unless we're paying for health instead of paying for number of visits or indicators that are not really important. We know that health is more than healthcare. It relies on tobacco, nutrition, economics, education, environmental, social factors. And we know that community health is really where it happens. And that's, I think, what we all got from our time, our privileged time, working with the Center for Health Services. Engaging people where they learn, where they work, and where they play. And working where it's needed most, urban and rural. So I really appreciate the chance to engage with you. I've often thought about the short time I spent in that work as one of the most exciting and most formative of my life. And so I'm looking forward to talking with you about what more we can do to combine communities, public health, primary care, because we will come out of this pandemic. It is not the zombie apocalypse. we are not all going to die. At least 99 or 199 out of 100 or 200 people who get this disease will survive it. Some of them with significant health problems after, but they will survive. And it's not going to affect everybody in the country. It's a bad pandemic, but frankly, it could be worse. It could be much more lethal than it is. What we're seeing is a recognition, I hope, that we are all in this together, that we do have common interests. And maybe, without getting political, depending on what happens in the rest of this year, we'll have some real opportunities in this country. And those opportunities will include the possibility of revisioning what is public health, what is health care, what is primary care at the national level and local level. So I'll stop there. I've blabbered on enough, and I look forward to learning from you, especially interested in what people could tell us about a primary care.
Thanks very much. I'd like to actually ask Bob Hartman to weigh in on this. Bob, you might want to, I'm not sure that Dr. Frieden was here when you introduced yourself and your situation, but if you could go ahead and tell him your background and what you've been doing for the last 30 years, you might be able to weigh in as well as anybody on what he just asked.
Thank you very much, Dr. Frieden. As Bob Hartman out in Pine Grove, California, the Sierra Foothills. Student Health Coalition, before you were there, Tom, 72 to 78, various summers, and then back in working in Upper East Tennessee, Mountain People's Health Councils for 4 years, drifted out to California in 1988. And then I was health officer from about 1999 to 2014, in addition to doing primary care and internal medicine in our small county. So you were head of CDC for six of those years when I was health officer, and really appreciate your profound knowledge and the leading of us during that time. So appreciate that a lot. Here in Amador County, my wife's sitting next to me. She's a retired nurse. We've been very active in the community, not only from a primary care standpoint, but public health standpoint, and numerous other issues that affect small rural counties in kind of different ways than they do in urban areas, such as domestic violence, unsheltered people, and the intense conservative nature of rural areas, which makes all of this work a little bit more difficult. To speak to your changing that needs to happen in primary care, I agree that we need to get away from the fee-for-service model. What happened here when the large organization that I was with until last summer, when I tried to retire, I'm back as deputy health officer now in our county. Well, what happened out here is there was an immediate switch to virtual visits, and I couldn't help but think that some of the reason for that obviously was coronavirus, keeping people out of the clinic, trying to keep people out of the emergency room that didn't need to be there. But also, I think some of it was the fact that the financial incentives are there for clinicians to see as many people as they can and increase their own income, increase that of the clinic and of the system. So I agree that we need to get to metrics that emphasize treatment, efficient, effective treatment of things like you mentioned, hypertension. It's just going to be a really long haul, but I think this coronavirus is an opportunity to look at our systems and look at our systems in a different way, look at our public health system in a different way. Certainly in California, the funding for public health over the last decade, instead of increasing after MERS and SARS, has decreased significantly. And that needs to reverse and stay reversed for a long, long period of time. So the challenges we face as we're reopening in California, in our area, are really centered around a very conservative county and the demands and the threats of what will happen if we don't open up. and people, because our case numbers have been low, people do not appreciate. They don't have that direct effect. They haven't seen their friends and their neighbors heading off to ICU because we have such a low caseload. So it's like it's not a reality. And those of us in public health talk about the 3 W's all the time. Every single word that comes out of our mouth includes, or every statement includes the 3 W's, but people really don't pay that much attention to it. So I think those are some of our major problems and issues and challenges going forward.
Yeah, I will say that the CDC was pretty much absent from the podium and the decision making nationally. And I was taken aback by the decision to extend the national lockdown for another month when many parts of the country didn't have any cases. I think it's kind of like a wave, right? If you jump too soon, the wave splashes over you. If you wait too late, you get swamped. New York City waited too late. A lot of the country jumped too soon at the federal request. But the places that got it just right could lock down strategically. We also, I think we have to admit, lockdown is a bad word. It's about, and I don't know a better word, it's closing the riskiest activities. At any point, outside is a lot safer than inside. And so it was never that you should stay home, but go out, go to the beach, take a walk, go to the park, but stay at least 6 feet away from other people. And if you're indoors, wear a mask. So I think we have to reimagine the reality. Lots of things are going to be different going forward. In terms of healthcare, virtual visits, telemedicine, team-based care, these are going to be really important. But I mean, I don't know whether you or others see, how can we engage community health workers more in the kind of work that goes on? And how can we have more of a focus on things like hypertension control, so we're looking at the outcomes, not just the volumes? I mean, I don't want to dominate. I'll just tell you one more story that was really formative for me. I was put in charge of tuberculosis when I was in New York City. I documented a really big outbreak of multi-drug resistant TB. And I worked really hard, did a lot of stuff. And then this guy named Carol Stieblo came. He really created the global strategy for tuberculosis. And he looked at the data and he asked me a question that changed my life. He said, Dr. Frieden, last year you diagnosed 3,811 patients. Yeah. And this book you wrote, this booklet, with all the epi, tells us all about them. I said, great. But it doesn't tell us the most important thing. What's that? It doesn't tell us how many of them you cured. And I was really ashamed because he was absolutely right. It was obvious. We hadn't focused on the most important thing. And I think if you don't focus on it, you're not going to do it. This is the case in COVID. That's what I wrote about in the Washington Post this morning, about how we have to focus on the key outcomes. And that's true in healthcare. And I think what I've concluded from all of the years of effort that didn't accomplish much is if you're not paying, it's not staying. You're just not going to be able to change the behavior of the healthcare system unless money is at stake.
Okay, thanks very much. We do, I just want to remind you, if you have questions, please send them via chat and I'll pass them along. And Dr. Frieden may want to interact with you about the question, but send them through me first. And we have 2 so far. One is from Erwin. There's been much talk about a vaccine being available, if not by the end of the year, then early next year. Is this talk or just wishful thinking?
Yes, I do think that we will have a vaccine, and thanks for putting the op-ed onto the chat so anyone can click there and see it. But there's a lot we don't know. How well will it work? Will it work for everyone? Will it have adverse events? How much of it will we have? Who should get it first? Does it require multiple doses? It's not like click, click, you got a vaccine. It's more like a rollout to healthcare workers first, and we still have a vaccine for measles, and it's a great vaccine, and 100,000 kids died from measles last year. We have a vaccine for flu. It's not a very good vaccine, and we have hundreds of thousands of hospitalizations each year. I don't know what happened. Did I do something with the screen? Okay.
You're fine from our standpoint.
Sorry?
You're fine from our standpoint.
Okay. So I would say that it's encouraging. I think it's predictable that it will be politicized. I mean, way too much of this response has been politicized. How in the world is it political to wear a mask or not? I mean, it's just outrageous. And it's ironic that now Fox News is saying, vaccine, greatest thing in the world. It's like, okay, but we have to be modulated, right? A vaccine is the single most important thing we can do. And we are seeing encouraging trends. So we're seeing more and more data that suggests that prior infection is protective. Something just came out yesterday that 59% of people who had antibodies had neutralizing antibodies. These were young, healthy sailors on the USS Roosevelt. So that doesn't prove that they're immune, and it doesn't show if they are, how long it's going to be, but it's encouraging. There's a primate model that shows encouraging response. So it looks like you can get immune to this virus, at least naturally, and probably by a vaccination. How well, how safely, for how long, no idea. So this is a long road. We're just at the beginning.
Margaret asked a question that's probably on many of our minds. Getting tested without the structure you described seems like a waste of time. I'll be wearing a mask, washing hands, and keeping distance regardless of the results. Can you make the case for getting tested in this current chaotic landscape?
So I think testing is a question of prioritization. I would test everyone admitted to a hospital because first off, you'll find some cases, symptoms and no symptoms. Second, you'll protect healthcare workers. And third, you'll stop outbreaks in hospitals. I would test anyone with symptoms of COVID, cough, fever, change in smell or taste. I would test all contacts to try to find that web of transmission. In congregate facilities, nursing homes, jails, prisons, homeless shelters, I would test everyone if there's a single positive case because you really can stop those outbreaks. And little known fact, City is still doing great work. They're helping nursing homes all over the country stop outbreaks and save lives. They're putting out hundreds of guidance documents. Their website is still the best place for information on this. They've had 1.3 billion clicks on their websites. Americans are voting with their clicks. They're still trusted by 85% of Americans. It's still the same 20,000 people there now who were there when I was there. They've got duct tape over their mouth. They're not allowed to speak. And so they're not allowed to explain what's happened. Did they make mistakes? Absolutely. We all do, and they did in this. Were they bad mistakes? Yeah. Was it just CDC? Doubt it. I'm sure there were other parts of the federal government that were contributing mightily to those mistakes. But, you know, maybe that's one reason they're not allowed to talk.
Yeah. I have a kind of a down in the weeds question about testing, which has to do with your opinion about broad-based community antibody testing, especially given the fact that there are only 3 or 4 tests that really show excellent sensitivity and specificity. And those, only one of them, I think, has been validated externally. So what's your opinion about, do we need to do that? Is it helpful? And how do we go about doing it if we need to do it?
Yeah, antibody testing is kind of, so far, really doesn't have a role. It's a lot of bad tests. We don't know what the positive tests mean. It may be that in time, we see that if you have a certain result on a certain test at a certain level, you really are immune for at least a certain period of time. And then maybe you'd be safer to go to work in a nursing home or elsewhere. That may be a future use. That's okay to think about. But right now, other than research, there's no practical value to positive serology that I've figured out. There's a question from Nancy. How can we change the flow of money in the healthcare system? We were talking about introduction of national health insurance in 1974. What happens when the health insurers report record second quarter earnings with high premiums and few paid out claims? I mean, this is fundamentally a political question there's some things can be done at the community level, state level, city level, but fundamentally a lot of these are national issues. I wonder a question. I've been thinking about the possibility of a soft gatekeeper function for primary care. What if you said to primary care practitioners, this is your caseload, these are your individuals, and we're going to capitate you, and we're going to basically give you X dollars no matter what, or X dollars as a base. If you do Y, we're cutting that by a certain percentage. If you do Z, we're increasing that by a certain percentage. So you have capitation with positive and negative incentives. And then you tell the patients, you say, I've got Bill Core right prominently on my screen, so I'm imagining Bill Core as a patient. Bill, you know, you're a patient of Bob there, and you can go to him unlimited with no copays. And I'm not prohibiting you from going to a specialist. But you go to a specialist, you have a 50% copay. If Bob sends you to a specialist, you have no copay. And maybe that's a soft gatekeeper function, so you don't get into the problem of, if you like your doctor, you can keep your doctor, gatekeeper, but maybe there's some way to have a soft gatekeeper function so that primary care could deliver much better value, get more dollars, and decrease healthcare costs globally. But you know, a friend of mine who works in this area, a great guy, said there are all these golems there with their coins in every part of the healthcare system, and they want to keep them. You know, one person's waste, fraud, and abuse is another person's profit margin.
Great quote. I have a question. Probably Robert Wyatt's interested in this too, but what's your feeling about starting schools?
Yeah, I think actually the case to close schools is much weaker than the case to close other things. For kids, this is like seasonal flu. For people over 60 and with underlying conditions, this is like the 1918 pandemic. Now, it's not so simple, because you're going to have to open schools by letting kids who have underlying conditions, that kid with leukemia, letting staff who have underlying conditions do it in a safe way, which might be from distance. You may have like an IEP, an individualized educational program. You're going to need reasonable accommodation for staff, and you're going to need to change the way you do some things. Less crowding, more cleaning, maybe masks. So I think we've got to get schools open. I wasn't sure we even had to close them, but we got to get them open. Because kids suffer without that, educationally and health, and communities can't get back on track. So I think it's not a question of whether, but how. That's just, I haven't said that strongly publicly, but that's my belief. Someone has asked, is there evidence COVID on fruit and vegetables at grocery stores? No, not really. When you go out, wash your hands when you come back. A friend of mine and I, Sam Dooley, who just joined us at Resolve actually on Monday, wrote a piece for Fox. I've been talking to Fox because I figure, why preach to the choir? And we wrote a piece, someone can Google it and send it around, on tips for safe shopping. Like, if you're really worried, here's what you can do. Otherwise, just bring things in and then wash your hands. But the bigger risk is the aisles, is other people, is being indoors near others. So wear a mask and so physically distance whenever you can. I don't like the term social distancing. We want to be socially together, but physically distant.
Carol Carpenter asked about federally qualified health centers being involved in contact tracing and whether that would be a good opportunity to combine primary care and public health.
I've seen this. I was just on the phone with a rural area that's doing that. So maybe doctors actually used to have a duty to warn the people who were contacts, and then that was changed to a right to warn. But really, you'd like the doctor to do that. It is, however, not a simple thing. You may get into people very upset. You may get, so we think there's potentially quite a role. I'm seeing so many old friends here. It's great to see Jean and Barb and others.
Well, Barb asked about community health workers and federal support for verifying their impact and thoughts on rural hospitals.
I think we have to change the way we pay. We have to come up with a way that incentivizes programs to have community health workers on staff. I think, just kind of urging progress isn't going to cut it. We have to change the financial incentives. And some of that is done by providing a global capitation so that programs can figure out, oh, I can hire 3 community health workers, for the cost of 1 advanced practice nurse, or 6 for the cost of a doctor, and they can go out and get my numbers up. But they're not going to do that unless they're held accountable for numbers. And I really want to emphasize hypertension. I can't emphasize it enough. Hypertension is the single leading preventable cause of death in this country. We spend, what is it now, $3.5 trillion on healthcare in this country. The single most important thing we get right half the time, 50% control rates. Flip a coin, you can do that well. Canada's at 70%. Kaiser's at 90%. And if we got to 70 or 90%, and it's also the leading cause of health disparities. Black Americans live 3, 4, 5 years shorter lives than white Americans, much more likely to have strokes and heart attacks. And treatment is simple, it's cheap, it's effective, it's safe, it's generic. So we need to do, this is what we're doing globally at Resolve to Save Lives. We're trying to. But we really need to be thinking of massive treatment for hypertension and not so worried about over-treatment. The much greater risk is under-treatment. It's already well proven now. 120 is better than 140. So if you're aiming for 120, at 140, you end up at 130, 120, don't worry, it's fine. For my, people I deal with their hypertension, I'd like to see it under 115. It's at 115. From 115 and up, your risk of dying from cardiovascular disease doubles with every 20 millimeters of mercury. Doubles. So lower is better, down to within reason. So I just can't emphasize enough the importance of scaling up treatment.
My old friend Pat Kalman has asked about how to incentivize government to provide funding for public health and public health workers.
Well, I failed. I tried for 8 years to do that at CDC. It's really tough. Right now, we're lobbying Congress to come up with a new way of funding public health that doesn't rely on either discretionary or mandatory funding, 2 different flavors of funding. But what I kind of hope is this pandemic has cost us trillions of dollars. So Republican Congressman Tom Cole said, it's a no-brainer to spend billions in order to save trillions. And I hope we'll see a renovation of public health, but the country's going to be broke for a long time. I think among friends I can be blunt, don't quote me here, but look what happened. You had a massive giveaway to rich people. And as a result, we have enormous budget deficits that the Republicans were terrified about under Obama and think are irrelevant now because it's their donors getting the money, not people who might actually need it. So we're going to be just as we were in prior. If there's a transition in November, it's going to be just like prior. You're going to inherit a place that is essentially in severe financial problems, and that's going to require quite a bit of creative work.
This is a little off topic, but since Sonia is still here, and she's been asked to serve on a committee to see about safely reopening our academic institution. And I was just wondering if she had any comments.
No, I'll listen to Dr. Frieden. Thank you.
Sonia, it's good to see you.
Good to see you.
Can I take? When were you at the coalition?
I wasn't actually. Rick was my epidemiology teacher, so he invited me to come today to listen to you. So anyway.
Wonderful. Honorary member.
Yes, I'm honorary member. Yes, I think so.
And Richard Couteau.
Richard, Dick passed away How many years ago, Erwin? 3 or 4 years ago, I believe. And I invited his wife to participate in this call, but I don't know if she's on it or not. I don't think so.
I heard that Jack Geiger is 94 and still with us.
I actually talked to him at the Flexner meetings a couple of years ago. We won an award for one of our interprofessional programs, and he won a Lifetime Achievement Award. And I sat and talked to him and said I had first met him actually in the Mississippi Delta when I was doing a 4th-year externship down there. And he was sharp as a tack. I think he was 94 then. So he's probably older now.
So Barb Clinton asks, she's been wanting to ask for years, is it true that when he was in the Student Health Coalition in West Tennessee, he was in the habit of driving the old car he had across roadless fields at high speed? And no, it's not. It is true that I was trying to learn to play the Chinese flute at that time, and I would go out into fields at night to play it. I never got, I mean, I'm not being modest, I played it terribly. I mean, I had no idea what it was supposed to sound like, and what I played was nothing like it was supposed to sound like. But one night while I was sitting on the car hood playing the flute, a fox thought it was a bird and started stalking me. So that ended my flute playing. But I did go very quickly between Memphis and Nashville many times. That's true. Possible to make that trip faster than you might think possible.
I think Paul Joffrian has a question about speaking with one voice. Data and guidance sharing with one voice. Can you say more about your idea for strategic isolation, stay at home, choose your term? Should it be regional, county by county?
I think so. We have a website, preventepidemics.org. We put out a lot of materials on it now. It's a little hard to find stuff, but one of the things that we've encouraged is an alert level, red, orange, yellow, green, to give people kind of like air quality to know how much COVID is reigning in your community these days. We're not there yet. We haven't figured out really how to do that well. The other thing we're promoting is a clear dashboard of what are the most important indicators. That's what the Washington Post article was about this morning. It's striking that the countries that really do a good job at this monitor very carefully stuff that we don't monitor at all. How many unlinked infections are there in your community? What proportion of your cases arise among quarantined contacts? What proportion of your cases have had symptoms for less than 3 days between symptom onset and isolation? If you measure things like that are really important, you can turn things around. This virus is here for a while, and so we better get better at managing it.
Yeah, I think that I keep seeing, as you are, comments about people just saying, as soon as we get a vaccine, we're going to be fine. Obviously not aware of the history of the success of vaccines, including flu vaccine for that matter, considering, the number of people that actually avail themselves of it and the success rate with it. So I'm not exactly sure how to transmit that information. I try and post articles daily, usually medical literature, every day, and I run into this frequently with people really not understanding the challenges of vaccines and what it's going to mean when we have it. And there are about 1/3 of people that say, I'm not taking it no matter what.
Well, all you have to do is say there's not enough to go around and everyone will want it. But there are 2 questions coming in. What's the huge racial disparity from? And I think fundamentally it's 3 things. Black and other underserved groups are more likely to be exposed because they're essential workers without adequate coverage, because they're living in crowded quarters, because they have more exposures generally. Second, they have more underlying chronic illness. And third, they have less access to health care. That's our best guess. But you know, it is a systemically racist society we live in, and we've done too little for too long about it. And I hope this moment will be a turning point. The other question was, I don't want to give that short shrift. It's so important, and so much more to be done. No, I do have to sign off in just about 3 minutes. But the question is the pandemic has highlighted from DEPA so many underlying problems, such as health disparities and how we fund healthcare. How do you recommend prioritizing these issues? That's a really tough question, right? So I would say the key thing is you prioritize the issue that you can do the most about, that we keep our powder dry, that we have good plans for what could be needed in terms of community health centers or community health workers or interprofessional care or new models of payment. And then we look for that moment of opportunity when when this can happen, whether it's at the national level or the state level or the community level. So I think basically you look at the maximum potential impact you can have, and then the politics and public health are the art of the possible. I got really lucky in my career. I was named health commissioner. I'd never heard of Mike Bloomberg before. He became New York City mayor, and I became the first person in history to be a health commissioner for a mayor who had a public health school named after him. And Bloomberg basically said, if it will save lives, we will do it. Doesn't matter the politics. He essentially bought the election fair and square. He funded it entirely. He didn't owe anything to anyone, and he was going to do what was right. And he really understands public health, kind of intuitively. I saw him once while giving a talk figure out the concept of years of life lost and discuss it. Like, you know, in my small sample size, the people who are self-made billionaires tend to be pretty smart. So I was very fortunate to see that. And what that meant was, at that moment, a lot was possible. So I looked at New York City. I looked at the deaths, because deaths are really the most important thing to try to prevent premature deaths. Tobacco was the major issue. I said, let's tax it. It's now $13 a pack in New York City. I said, let's make it easy to quit. We made, you could call 311 and get a month of nicotine patches. I said, let's saturate the airwaves with good data showing the reality of what smoking does. It's not the Marlboro Man, it's gasping for breath. And so that led to the Tips from Former Smokers campaign at CDC. And we made all public places smoke free. So they're really expensive to buy. You can't smoke them in most places. And when you smoke them, you get some awful associations of people who look really disabled and disfigured. So with that, we were able to drive smoking way down, but that was because that was the moment when it was possible. So it's the art of the possible.
Thank you so much. I know that you're about out of time. I'm not sure I can thank you enough for your for participating in this with us, and a great way to kick off our conference. And especially proud that you feel that at some point Center for Health Services and Student Health Coalition helped start you on your way, and certainly you've exceeded all of our expectations of you.
Can I just say hi to Jean Carney?
Absolutely.
It's so nice to see you again.
Rick, this is Bill. Could I say a quick thank you?
Can you hear Bill?
Yes.
Tom, I just want to say a quick thank you to Tom for being with us, of course, by telling a story. Tom, the first week of March, I had a friend say to me, this pandemic is looking pretty serious. You know, what do we need to do? And I said, give me one thing I can do, and that would be, you got to bring Tom Frieden back to CDC, and he's got to be the one that tells us how to go forward. So thank you for your career and all your commitment and all the great work you've done. And thank you for continuing it, because you're not just saving the U.S. now, you're saving the world. So we really appreciate you being here with us today.
Well, thank all of you for the great work that you do. and keep on teaching people, keep on strengthening community, because that's where it's really at. Jean and Barb and everybody else, it's great to see you. It's great to know you're still strong.
Thank you so much. We appreciate you.
All right, thank you. All the best.
Thank you. And our next session will be this afternoon. Erwin, do you want to discuss that?
Sure. This afternoon, Biff Hollingsworth and Chaitra Powell will give an update on the status of the archive. You know, we've been functioning with them under a Mellon grant for the last couple of years. That grant is about to be finish up, and they will sort of tell us a little bit about the future of the community-driven archive project, which will lead to our discussions tomorrow about our budget going forward. And then tomorrow afternoon, we'll have a discussion led by Nancy Rabin and Polly MacArthur on creating a Mentors Legacy Fund to honor those community members and leaders who we worked with over the years. So hope we can join us tomorrow, this afternoon, and tomorrow as well.
Thank you all very much, and look forward to seeing you later. I believe you can log on using the same link that you used to get here for this afternoon's meeting. Is that correct, Sonoe or Chaitra?
It'll be a different link.
Oh, it'll be a different link.
It's a different link every time. This is Margaret /Muffy. And the link